Thank you and good morning, and thank you for inviting me in this wonderful conference. So drug-coated balloon mechanisms of action, as all of you know, that we really use the drug that has been used uniformly for all drug-coated balloons has been the paclitaxel. And paclitaxel, how does it work? It prevents microtubular depolarization and arrests the cells in the mitotic phase between the G2 and the M phase. And if you look at after an arterial injury, there are all kinds of cytokines, growth factors that are released, and that this goes on for good 60 days, during which smooth muscle cell proliferation occurs, as shown here. These are the various time points, and you see macrophage infiltration, you see collagen proteoglycan deposition, and this goes on. And therefore, we need drug as a target artery in the target artery for a long period of time. So what does paclitaxel do? Basically, it inhibits smooth muscle cell proliferation as a response to injury. Can I get the... Okay. The elements of effectiveness of drug-coated balloons, what do we need? I think we must deliver large quantities of drug within seconds in the drug-coated balloon. It must distribute within the media in the first few days. The therapeutic drug levels must be maintained for several weeks. As I showed you, it is essential to have the drug since cell proliferation occurs over a long time, must allow rapid healing as compared to drug-eluting stents, and I'll show the differences. There should be no need for long-term dual antiplatelet therapy, and the biological effects must be observed in preclinical studies at 28 days. This is a way of making sure that this drug-coated balloon is effective. I'm sorry that it's skipping. So if you look at the differences, are there differences between drug-coated stents versus drug-coated balloons, that drug-eluting stents? So if you look at the concentration overall of the drug, it is actually very low as compared to what we need in DCBs. And drug transfer in the case of drug-eluting stents is slow, but it is rapid. In the case, has to be rapid in drug-coated balloons because we've got to deliver it within that short period. We usually have a reservoir of the drug in drug-eluting stents, that is the polymer. Whereas here in drug-coated balloons, we have no polymer. We have an excipient, which is an important component of it that allows the drug to stay there for a time. Drug retention in tissue is short in the case of drug-coated stents, relatively short, I should say, whereas in the case of drug-coated balloons, it must be long because we need to keep it retained for a long time so that beyond 60 days, we still see an effect of the drug. The diffusion should be good, but in the case of drug-coated balloons, it should be excellent. Lipophilic, I think you need it highly lipophilic, even better than what we see it in drug-eluting stents. The active ingredient, it's not necessary. It can have an active ingredient and therefore can be converted to the active ingredient, but should be active in the case of drug-coated balloons because we need an action almost immediately. And as shown here, you can see the distribution of the drug in green fluorescence. In the case of stent, you can see very well it is where the stent makes an impression of the arterial wall, whereas the drug-coated balloon has the advantage that it can be distributed throughout the arterial wall. And the disadvantages, of course, you see uncovered struts, and you also see that there is delayed healing. So what about Zilver PTX, which is used in the peripheral arteries and has excellent results? You can see that this is used in a self-expanding nitinol stent. There's no polymer or binding. There is 3 microgram per millimeter square dose density, and these are the various levels in the sense the amount of drug depends on the length of the balloon. And as you can see here, overall freedom from target lesion revascularization is very low at 5 years, close to 85%. Also, the stent thrombosis rate is very low, up to 1 year. It is less than 2%. So extremely effective. The drug-coated stents are effective, not to say they are not effective. But what about drug-coated balloons? And if you look at if we give paclitaxel alone, tissue concentration is only at 1 hour we see within the arterial wall, but we see nothing afterwards. Whereas if you have a excipient like the iodopromide in the case of sequin please balloon, you can see very well that we see drug present up to 3 days in this case and longer. And if you look at blood concentration, basically you see very high levels in the case of when you give it just paclitaxel or without anything, whereas if you give it with the iodopromide, the levels are much lower because the drug stays in the arterial wall. So if you look at the effects, you can see very effective that only the effect is seen in the iodopromide. That is, you have to have an excipient so the drug can be retained. This is just to show you in the arterial wall, if you do 1 balloon, 4 balloons, 6 balloons, you can see very well the drug effects. You can see the crystalline material, you can see fibrin, you can see the loss of smooth muscle cells as shown here. So what are the drug-coated balloon devices that are available in the US? There is the Impact Admiral balloon, which is available from Medtronic. You can see the Lutonics from the Bard. And then there are others which are on the way, the StellarX and Surveil. And I'll just show some of them. As you can see, the highest drug levels is present in the Impact versus the other 3 balloons, which are two of them about to come on the market. One already is 2 micrograms. So these 2 have CE mark. These have the StellarX has CE mark, but not FDA approved. These 2 are not FDA approved. So the coating integrity, I think, is very important. If you look at the Lutonics, you can see very nice coating, whereas if you look at the Impact, you can see that there is quite powdery, and whereas if you look at the Surveil, it seems very smooth, and surface coverage seems quite extensive, as shown here. And the integrity, and I'll show you what are the pharmacokinetics. You can see very well pharmacokinetics that you can see drug present in case of Lutonics up to 180 days. And what is the level which prevents smooth muscle cell proliferation is very low. 1 nanogram per gram is all you require to be inhibit. So therefore, this balloon should be effective for a long time. What about Impact? You can see that they've done their own homework showing that Impact versus Lutonics, they show higher drug levels in theirs. And this is a comparison, although not done in the same time in the same animals. You can see still overall that although the balloon also carries the highest amount of drug, it also seems to have the highest drug in the arterial wall. So what about Surmodics? What they did, they compared their Surveil balloon to that of the competitor DCB, which is the highest one. And you can see that theirs is 2 microgram, and with a 3.5 microgram, you can see it's a lower level as compared to what we see in the case of Surmodics. So if you look at StellarX, similarly, they show, even though they carry 2 micrograms, they show a much higher level as compared to the other 2. When you look at 30 days, these are comparators, stent A and drug-coated balloons A and B, with 2 microgram as well as with a 3.5 microgram. So what are the histologic parameters that we ought to look for? The key parameters are look for endothelial loss. You should look for fibrin platelet deposition as shown here. You should look for inflammation, which is usually very low. If you look at injury, there should be injury in the arterial wall. And you should see, to me, the most important is smooth muscle cell loss. This is both circumferential as well as transmural. As you can see here, this is smooth muscle cell loss area. Smooth muscle cells are staining brown. Where there's absence, you can see. And you're looking for proteoglycans. Overall, you can see a comparison at 28 days in the pig model. You can see smooth muscle cell loss depth, Impact Lutonics. You can see here no differences. Smooth circumferential, no difference. Proteoglycan, no difference. And fibrin deposition is no different. So what about Impact? They believe they require crystallinity. They've kept the crystallinity on the surface, and that it is effective in releasing the drug for a long time and prevents smooth muscle cell proliferation and deposition in the media and normal arteries. If you look at overall the duration, you can see that it seems to have blue shown in admiral. You can see seems to persist for longer at a higher level. The effects are much circumference as well as in depth, loss of smooth muscle cells. What about the biological effects in case of SURVEIL? They show even better, as you can see here very well. So distal emboli are important to look for, are there any changes that is eosinophilic or not. You can see each balloon has its own, but we always see distal emboli somewhat. We must not see too many. Overall, you can see in admiral impact, we see much greater emboli, whether it's 28 days or 90 days. And the drug levels are also significantly greater in the impact in the skeletal muscle as well as in the coronary bands. So aneurysm formation has been reported. I don't have time to go through, but this can be a complication. Downstream effects in the skeletal muscle, you can get necrosis if there are distal emboli, and this is in a patient. So I'd like to summarize by saying not all balloons are created equal. I think you have to, what is your goal? Overall is efficacy. There should be less neoanthema, absence of restenosis, late thrombosis, no late thrombosis, and biological no emboli. If you look at, we want no complications, that is, there should be rapid healing, re-endothelialization, and no distal emboli, no aneurysms, no embolic disease. Thank you so much.